Awesome. Okay, welcome to the podcast. This is Season 2, Strength and Chiro Podcast, Episode 6. Can you confirm for me, Dr. Stephen Redman, that this is Episode 6?
I believe it is.
I need that confirmation. And right before I introduce our guest, can we have a quick dog check?
He is down here on the floor. I don't know if I'm going to get
the formalities we must get out of the way, you got to pay respects to the dog. There he is. I would like to have a dog cam, so we could see the dog, but we don't. Budget's tight. We're really excited today to have an absolute legend on the show. It's our pleasure to have him, especially tuning in all the way over from the UK. We're on 3 different timelines. It's one of the cool things about this podcast is I love the different timelines. It keeps me sharp. For me, it's 7:30 a.m. start, Monday for me, Sunday for Stephen, 3:30 p.m. And it is pretty much nighttime for MOFO. It was 8:30 p.m. Sunday.
Yeah, 8:30 p.m. Sunday.
Without further ado, I'd like to introduce Aaron MOFO, the body mechanic, to the podcast. First things first, I have a burning question. Does MOFO stand for motherfucker?
I think in my client's eyes, it probably does. So most of the people I know, when I've got an elbow into their glutes or elbow in somewhere, it's motherfucker. It stands for minority of one. So throughout my career, whether that be in the Air Force or at uni or as a cyclist, I've always walked my own path. I've always been a bit of a maverick. So I had a PDR. So in the forces, they do a review of you every year, and it's usually like a 2-page review. And I walked in for my review. Normally takes like half an hour, and he said, "Corporal Caseley, you are an enigma." And I said, "Thank you very much, sir." And he said, "Any questions?" And I said, "Yeah, what's an enigma?" I knew what an enigma was. I was just being ironic at the time.
Yeah.
But I took that as a compliment. And I think throughout my career, that has stuck. So when we came up with the idea for MOFO, I looked for synonyms of enigma and maverick, and minority of one was that synonym, which conveniently shortens down to MOFO.
And it's funny because based on,
tattooed on my neck.
Oh, there you go. Based on your persona, your personality, you seem like a very funny, cheeky, type of guy. So I just assumed that it would mean exactly what I thought it meant. You know what I mean? It has this deep meaning to it, which is, hey, it's fantastic. Much respect. I'm glad I asked.
And I think that's the beauty. I think the dichotomy of me being that cheeky chappy that people think, and then the deeper meaning behind that, I think is what I think people are always surprised at when they meet me. I think they expect, kind of dumbass, cheeky chap, performers in front of the camera. Yeah. And actually, steeped in academia, published in several peer-reviewed journals. Yeah. It's like, so I like the fact that I look, I'm covered in tattoos. I look a certain way and people judge you based on, the book and cover. I like to surprise them.
You're absolutely right, and I'm similar. I've got tattoos on my arms, and I'm a big dude, and I feel like I definitely get typecast. I was at my son's 5th party, and one of the dads, I said, "Oh, what do you do, mate?" I was creating conversation, and he goes, "Oh, you wouldn't get it." I said, "Oh, try me," He's like, "Oh, it's got to do with, it's kind of like, let's just say I do IT." He goes, "Oh, let's just say that." I'm like, "Mate, you can give it a go, But he's like, he just kind of wrote me off, I think, And it's interesting how that happens. And even that happens when I deal with other industry professionals as well. I've had a lot of physiotherapists and different types of therapists come at me, with the whole thing of like, "Oh, well, this person shouldn't be doing powerlifting," and I'm like, whoa. They haven't ever been doing powerlifting unless that's been their goal, So it's funny how someone's past or someone's appearance can really change how people perceive you. But especially when I was a strength coach working with other professionals, that was something that I came up against. And it's like, man, these professionals don't understand movement at all. Some of these people, and they just, what they don't know, they don't understand, they fear. And what they kind of fear, they judge. You're just like, man, I'm not the one here that needs to read a textbook. Well, get in the gym rather. Dr. David Johnson, the CFMC, the neurosurgeon head of CFMC, he says, when we're hiring people to be trainers, we're not looking at their resume as much as we're looking at the calluses on their hands.
Absolutely. Yeah. Yeah, look at those.
And we all have
Yeah.
some of those here.
Absolutely. And you know, it's interesting you talk about. I didn't realise you were a strength coach. That was my background. I was an S&C coach before I became an osteopath. I think the problem with a lot of what I see in terms of certainly UK rehabilitation is they haven't got the first idea. What they're prescribing isn't movements. It's early stage rehab. You know, it's therabands post surgery. Yep. But they're doing this 6 months, 12 months, 18 months after the injury. And, you know, I think that particular set of skills, to take a Liam Neeson phrase from Taken, makes us very dangerous to people like them.
Oh, yeah. They're threatened. But it takes years. It takes sweat, tears, years in the gym. And it's not something that you can pick up in a course, in a book. It's something where you really have to put yourself under the load, under the bar, and you kind of have to earn it. And I think it's very easy for people to scoff at that when they haven't achieved that.
Yeah.
But hey, real quick, I will officially introduce you because I've got some stuff here, and then I'll just make sure I introduce Stephen to his own podcast. You know him as Redman. I call him Red Mod. Most people know him as Tony Stark, Iron Man of chiropractic. Welcome to your own podcast, Dr. Stephen Redman.
Thank you, Rogan.
I can see the resemblance.
Yeah, I like to throw that in there. You know, just throw respect where it's due. Stephen's
Respect Iron Man where Iron Man is due.
And to the true guest of this podcast. That's enough talking about you, Stephen, all right? Relax. To the true guest of this podcast, MOFO, and, you know, now we had the understanding of what that means is even cooler. You have I put this on social media yesterday, very impressive pass, right? As you mentioned, Air Force, right? A long stint as a personal trainer, osteotherapist, exercise scientist, 15 plus years of, you know, teaching experience, academic experience, elite athlete, cyclist, powerlifter. You have peer-reviewed published articles and research. You have been on peer-reviewed panels yourself. You have 5 kids and 2 grandchildren. I think that's the criteria of legendary status has been achieved.
And 2 whippets and a 3-legged cat.
Oh, wow. That's the cherry on top. So
it's the cherry on top.
Is there anything else you would like to add to that for the listeners?
No, I think that's plenty to be going on with.
I try to introduce people fairly relaxed, and I remember I was really stressed when the first time I had Dr. Locke on I wasn't stressed, but I was cautious about having Dr. Locke on because I really wanted it to be great. And I spent all this time, you know, Googling and figuring out what I can, and I read this long thing about everything he's done, and he was like, he's like, there's more stuff you haven't said, and I was like, oh. You know, like thanks a lot, man. You know, like I put my heart and soul into that. Like I was up late last night researching it. But man, just like yourself, that guy has a very impressive history of things that he's been able to achieve, and half the stuff he's done playing professional sports as a kid, baseball, all the stuff I didn't even know about. You know, until he starts telling me. I'm like, oh, to go back and add that in.
He's lucky. He's Australian, isn't he?
Yeah.
They play baseball in Australia. He's an Aussie.
Mate, you know, it's something I wonder too. It's a very strange sport to play, but we do play a little bit in New Zealand, a little bit in Australia, and he went to America on a scholarship, from what I understand.
Okay, well, that explains it then.
I think he was a pitcher, which got him into shoulder issues, and then he was actually a shoulder specialist in the early years. His postgraduate clinic, when he was working for this lady, she said to him, become an expert at something, but it can't be shoulders because that's what I do. And he goes, oh, I'm done a lot. And so he became a lower back specialist. And
so he chose the most difficult part of the body. He chose the lower back.
Exactly right. That's exactly what he did. Anyway, I've got questions that I want to ask. Okay, let's start here. Why, in your opinion, is movement so important?
I think when I was in the 40s, I worked at Headley Court, which back then was a tri-service rehabilitation centre. Now we were dealing with, you know, these weren't, you know, sports injuries. These were bomb blasts. These were IEDs. So we had head injuries, spinal cord injuries, limbs blown off. And what you start to realise about movement is it drives everything. Digestion, respiration, you know, so people who've been bedbound for weeks, they were also constipated. There was no peristalsis taking place in the intestines. They were getting respiratory infections all the time. So I think from a general movement perspective, that's where I started to become more interested in, I suppose, movements. But as a therapy, It was there. So as an S&C coach, which was my job in the forces essentially, when I went to Headley Court, there was a physio school at Headley Court, and I'd watch the physios doing their TheraBand resistance exercises with their clients, and I'd be doing regressions or progressions of deadlifts and regressions and progressions of squats and regressions and progressions of bench. And it got to the point where there was almost bad blood between the two sort of parties. I was a rehabilitation instructor. I wasn't a physio at this point, because I was getting people better and they weren't, because they were using, basically early stage rehab interventions. And I think that for me, even when I went to uni and did my osteopathy degree, I still question the merits of a purely hands-on approach. Everything I did, I remember I think it was my first clinic session as a first year. The fourth year student went out of the clinic room, and I stayed in the clinic room with the patient and basically gave her a load of rehab exercises to do and said, you don't need to keep coming back here every week. Just do these and your back will sort itself out. So I think for me, I've always questioned, we talked about passive and active treatments. I think I've always questioned the merits of a solely passive approach. I think in favour of a passive and active, combining those two things together. So you're giving people symptomatic relief, and then you're giving them stuff to do which actually fixes the problem.
Yeah, and when we look at the research, it's evident that there are good outcomes with various passive modalities, and we can admit that. Like I said, we're evidence-informed, evidence-based people. But when you look at the exercise, it's very overwhelming. Strength training, cardiovascular training is very overwhelming. So in line with that thought, why do you think it's so hard for other therapists to get on board with active modalities? And why do you think, in a sense, they're almost kind of scared of what they don't understand, but it's not really that hard to grasp, I think. So what's your opinion on that?
Having worked in education, I taught physio, I taught osteopathy, I taught sport and exercise therapy, which is like athletic trainers in the in the US. So 15 years of education. And I think the real reason is the curriculums, certainly in the UK, don't cover exercise prescription in any way, great, shape or form. So with the physios, when I was in Birmingham, my first session with the first year physio students was I went into the gym. I showed them how to deadlift, squat, and bench press. I showed them how to regress and progress those movements. And essentially, if you can teach your client to do a regression or progression of those three, the big three, I said, you can pretty much rehab anything. And then you go to exams, and because they've been spoon-fed by other health professionals that were teaching on the course at the same time, they'd come in with their TheraBand and their kind of banded rotations, and I'd look and think, like, where's that gone? And so I think certainly in the UK, there's a missing link, I think is probably the best way to describe it.
Yeah, that makes a lot of sense. And I agree with, what you're saying, definitely agree with that. One idea that comes to mind is when we were talking to Dr. Mike Woodbury. He's a chiropractor out of America, and he deals with a lot of powerlifters exclusively. And I remember him saying to me, man, like giving people bird dogs or TheraBand or basic movements like this, for these kind of injuries is like trying to put out a house fire with a water gun. He's like, rehabilitation needs to be based on these three main movements, meaning a press, a pull, and a squat. And quite often it needs to be movement led and heavy, enough to really create a stimulus for that type of person, which would be a powerlifter in this context. But it's often, very similar to even general population. The problem with general population is they have a very low baseline, if any at all. I am interested to know, real quick, throwing to you, Dr. Stephen, based on what we were just talking about, is the curriculum just as bad in the US regarding exercise education?
I would say collectively it probably is. I know we've talked about it a little bit, Brogan, and it's definitely an issue that a lot of times I've talked about it with this guy who's getting ready to go to chiropractic school, and he's getting an exercise science degree right now. And a lot of the professors we have in universities, they're not necessarily exercise focused. They have a PhD, they have a master's degree. They're teaching because they have to. A lot of times they're doing research and they're really just at the university to do research and they have to teach. So if they don't understand the complexity of the information that they're teaching, they're going to teach it at a subpar level and they're not going to necessarily always disclose that to the student because they're an authority figure. They want the students to respect them. So it kind of waters down things. I know in my undergrad, whenever I went there, we did have a little bit of exercise prescription, but it was very, very superficial. And then later on in the program, you could take more advanced classes on it, which I did do. And the more advanced classes were great. Like the very first class was really a joke. Then in the X-Phys class, it really depended on who you had. So when I took X-Phys, I specifically chose to take it with the lab, with the strength and conditioning coach, where they were on top of all of the movements and all of that stuff. But other people, they didn't necessarily do that. They take it with the just any random person or the person who supposedly had the easiest lab.
Yeah, exactly. Stephen has a similar background to yourself, MOFO, in terms of, you do peer review, Stephen, obviously doctor of chiropractic, but your undergrad was exercise science and registered manual therapist, massage therapist, covers all those bases in a similar way, hence why I threw that. And also you're a lecturer, an educator as well. So that's why I wanted to throw that question to you to hear your thoughts on that. Many people are aware of where the link breaks down. And I know, for example, like Dr. Locke talks about this because he provides a lot of post-education type training, travels the world trying to, I suppose, bridge that link, you know what I mean, between people that are graduating. Why do you think people that graduate, why do you think all these new grads get sucked into these, self-appointed gurus so quickly? Like, I find there's just, you go on someone's post and there's just, a lot of people that are having good discussion, and then you can almost pick out the person that is a new grad who's just, repeating something that one of those types of more aggressive people online have said, and you can almost pick. Why do you think an issue there?
Well, I think because you leave university as you don't really know anything. I think if
that's the truth.
You leave university having spent 3-4 years doing your undergrad, and actually jack shit about injuries, and you've done some clinical supervision, but you're under the supervision of a qualified tutor. We had to accrue, I think it was 1,000 hours of clinical experience before we graduated. And I remember leaving, and my first back pain patient, I was shitting my pants, thinking, fuck, like, it could be a disc, it could be a facet joint, it could be this, it could be a rib, it could be, And I think what those people on social media have is they're authoritative and they are convincing. And I think as a new grad looking for leadership, we talked about this earlier, I think they offer those, rabbit and headlight new grads something to hang on to.
Yep.
And the problem is when you scratch the surface with those people, because I've had similar conversations with people on my social media posts, their argument crumbles because it is just regurgitation of somebody else's words. And I think that's the problem. I think they're very convincing and they're very authoritative. And I think, in an industry that you have to be happy in the grey, I think we want black and white. We want to join the dots, and these people join the dots for them.
Even if they're pointing them in the wrong direction at times.
Even if they're pointing them in the wrong direction, absolutely. Yeah.
I think that's why it's so important we give people in the industry that are doing things right a platform like yourself, and people in the industry that are like-minded need to get together and discuss these things so that people have a framework that they can work from. And I get heaps of messages, of people being like, oh, thanks for talking about this, thanks for addressing this, because other people don't. And a lot of those people that act like they call out people and they're aggressive and they don't care about it. They're just going to say what they want. They're actually following the script a lot more than you'd think.
Yeah.
And that's actually the funny thing. Once you understand full context of a situation, especially rehabilitation, you can pick the fakes and it's quote unquote, whatever. But for example, there's times where the one person in particular who talks with authority, picks up research articles, reads abstracts and conclusions. You can tell there's no full context. They're not reading full papers, and they will misrepresent data. And then they're saying, okay, this is an exercise that you should do. And for the first time in, many videos, they're showing themselves do it with a barbell. And immediately, as soon as they picked up their barbell, I could tell they have not done their 1,000 hours. They have not done their 10,000 hours. They have not done their 100,000 hours. You know what I mean? Like I sent it to 10 people and I said, spot what I'm saying. And immediately the people that I knew, that guy's really unco with that bar. I'm like, dude's never picked it. I feel like that dude's picked that bar up maybe 5 times before in his life. And the only way to know that is through experience.
Yeah, I 100% agree with you. And I think I started lifting when I was 10. So I was a county standard breaststroke swimmer when I was about 10 years old. And I bought a Sandfield set of York, the old Sandfield dumbbell and barbell kit.
Yeah.
I don't know if you guys have Argos over there, but there's the Argos is like this little chain of shops in the UK, and it sells like cheap cut price. So I had this in my bedroom. Now back in this was the 80s. The only handbook of training I could find was Arnold's Encyclopedia of Bodybuilding.
Yes.
So I was doing squats and dumbbell pullovers to try and increase my chest capacity, because I used to think back then VO2 max was all about how big your chest was. And then I think I've always, I can honestly say, whatever sport I've done, as a cyclist, I was lifting. I played rugby for the RAF, I was lifting. I was a triathlete, I was lifting. Lifting is something that has been with me all my life and will be with me all my life. And exactly as you say, I think it gives you a currency. And I think one of the reasons why I continue to train and I continue to promote lifting is because it's one of those things. I mean, there's more and more research coming out now about, muscle being an endocrine organ, its role in terms of protection of brain, in terms of neurotransmitters. But I think that from a rehabilitation perspective, you can't really go wrong with strength. You can stretch things to death and, cause more problems than it's worth. But I think strength training like I say, it's been something that I think gives me a certain amount of currency with the people I work with. I started powerlifting as a social experiment. There's a big movement. Again, I don't know how people train in New Zealand or the US, but progressive overload has become king, or linear progression, as it's actually called, has become king in terms of building muscle and building strength in the UK. And I wanted to show people that you could use tempos, you can use time under tension, you can use all these different variables. So my powerlifting foray was more about showing people a different way to train, which is still just as effective, and trying to reduce injuries. Because like in the world of strength, again in the UK, I would say that 90% of the injuries that I see are tendon related.
Yeah.
And 90% of the injuries are due to overtraining those tendons, too much load, too frequently, or too little, too infrequently.
Yeah, I recently had a friend reach out and he said, I've got this powerlifter, he's a patient and he's got back problems, and he laid down on the table and his erectors are like rocks. And he was just kind of quizzing me. He was like, what do you think would be the best course of action? I said straight away, you need to look at his training. You need to look at his frequency, his total volume. You need to look at the poundage or the intensity, and then also the movements, right? And that in itself, I said, you'd be able to fix this dude up just by adjusting his training, I would say, because powerlifters love to overdo it. And usually also, there are a lot of people out there that think they can do it on their own, so they'll go on it, they'll do their own stuff. They'll go off something from the web, a Google program, Or they'll hire someone that is a good powerlifter themselves, but maybe doesn't have the adequate experience or knowledge or education, and they'll get stuck in a progressive model, or they'll get thrown straight into a conjugate model when they're a new beginner natural lifter, and it may not be appropriate.
Yeah.
And what you find is when people come to you and they have these aches and issues and even tendon problems, it's like, a lot of the time I'm saying, let's just have a look at the program. I don't even have to put my hand, I don't even have to touch you. Let's just have a look at your program. Unfortunately, more times than not, there's something that pops up. If something doesn't pop up, the next thing is, let's have a look at how you're lifting. And
100%.
Then something pops up pretty much always, because, man, this is the biggest thing. I just don't see many therapists who really understand how to execute proper movement. It's just such a minority. And unfortunately, touching on tendon issues, we covered in one of the last podcasts, I shared a story about a person that had a tendon problem, and they said, I went to the doctor. The doctor said I have to stop lifting. I'm not lifting for the next few months, and I have to do this so that I can get back on my feet, and it sucks, but I got to do it, and all this. And I let all the boys have their go at it. And what do you think? What do you think? And everyone was like, tendons need load, we need to have movement. And it's just this dichotomy. It's just this differentiation between what these kind of doctors get told and what they tell their patients versus kind of what needs to happen. Throw them on some drugs, ibuprofen, give them something for the pain relief and tell them to stop moving. Why is that such a problem in modern healthcare, in your opinion?
Well, I think in terms of medicine, it's big pharma drives things. If they can give them some anti-inflammatories and pain meds, they're being paid, aren't they, essentially? I know that's a very cynical way of looking at it. I don't know. I mean, it's the same for physio in the UK. So I get loads of people come and see me. The physio's told me to rest for 6 weeks or 8 weeks, 12 weeks. And I talk about, parallel bundles of collagen and the disorganization that takes place. And they go, so it needs loading. And I go, yeah, it needs loading, but it needs stimulating, not annihilating. Yeah. And it needs then time to adapt. And I think that's what people misunderstand and misconstrue. Yeah. And like you, I spend a lot of time these days online, and people say to me, how do you diagnose an injury online? Well, I look at the training and I go, well, that's your problem. Or I look at moving and I go, that's your problem. And if it isn't one of those two things, then it's probably something that needs some kind of MRI, CT, some sort of scan, some medical imaging. I would say 90% of the stuff that I see is training or movement related.
And the thing with, I suppose, when you're seeing a demographic of lifters, you can look at that training and things like that. But when you're seeing a demographic of general population, it becomes a little more complicated, because now you're going to take a really comprehensive history and figure out, where's the overload coming from? Are they getting in and out of their car the wrong way 1,000 times per year? Or are they vacuuming? I know those, man, they can be provocative, those types of things. Getting out of bed wrong, vacuuming wrong, getting it out of the car wrong. Even just having an altered gait, just not really realizing, and I suppose that makes things a lot more complicated, doesn't it? When you have to look at someone's whole life.
It doesn't. I mean, I think, again, it's interesting. One of the most common questions I get from people coming onto the program, am I going to lose muscle? And I'm like, no. I said, unless we ship you off to the International Space Station, where you're working in a zero gravity environment, you are working against load all day, every day, gravity. And I said, so the likelihood of you losing muscle, even though we're bringing the intensity down, I said, is minimal. I said, because we're still providing the stimulation. I said, we might be using tempo to stimulate, or time under tension to stimulate. We might be using metabolic stress to. But essentially, I think with day-to-day athletes, the general population, I think a lot of those are led by, certainly in the UK, they're led by PTs in the UK, who've only been taught one model of progressive overload in terms of training. And I think it comes down to the same things. Yes, they are doing more stuff outside of their training, their sport, but ultimately that overload is still coming from those 3 or 4 PT sessions a week, where the PT is absolutely thrashing that person to within an inch of their life with awful form. And I was watching a guy the other day. Oh, yeah. He was doing deadlift. He was doing deadlift endurance. I'm not even sure what that is.
Yeah.
190 kgs for 15 reps. And I watched his first 2 reps, and they didn't look too bad coming off the floor. And then from rep 2 to rep 15, it was horrible. And it got more horrible every rep he got as he got into that seat, into the red zone.
Yeah.
And I'm like, why? Like, that's not doing anything. That's not hypertrophy. That's not strength. That's just, it's like assaulting your body. 15 reps of 190 kilo deadlifts.
People like to, I've noticed people like to do really obscure and random things because it makes them appear as though they have a plan, and everyone else doesn't know what they're doing because it's just a bad plan. But that makes them almost seem different to everyone else, especially celebrity trainers. But what I was meaning before, more so about our general population, I was meaning the type of people that don't train at all. So that's what I'm saying. So in regards to what you're saying, looking at those training sessions, and even jumping on what you're saying with the personal training thing, I mean, that's a real problem. We can sit here and talk about this stuff all day long, but if there is a massive portion of the healthcare profession at the bottom of the healthcare profession that's not getting the education they need, and they're doing more harm than good at this point.
Yeah.
And I've seen it happen time and time again. And I've been involved in gyms in the past where I've made a real effort to try and I've worked with the gym manager and made a real effort to clean up the technique of everyone in the gym, everyone at least that's under a personal trainer. And, we would see injuries happening all the time. And the hard thing is that you would come in to a class or a group of people that you were coaching, and they're being told by so many personal trainers over the previous weeks, years, months, who knows, that their form's okay, that they don't listen to you. You say, look, we're gonna turn over a new leaf. We're working on this, and they look at you like, I've been doing this for 5 years, mate, or 10 years, or 20 years. I know what I'm doing. And they're doing a kettlebell swing wrong, a squat wrong, basic push, pull, everything, hinge, everything's terrible. They're constantly hurting themselves. The very thing that's meant to help them is the thing that's causing the problem. So I completely, I kind of understand that kind of thing. What's interesting, I suppose, especially for someone like you, Stephen, what I'd be interested to know, for context, for you, MOFO, Steve worked in a part-time, he worked in a really high pace clinic, right? That meant that sometimes you saw 70 people a day, and you'd see them for minutes at a time. And so this was something he strategically did to get better at his skills, his interventions. For you, Stephen, did you even have time to talk about some of the exercise-based stuff in those environments? And if you saw your someone coming in and you could notice they're getting on the table wrong, or they're sitting strangely, or whatever, like, did you ever have you did the adjustment, you did that, and then you kind of have a little bit of time to do education as well, or was it just too fast, too short?
It would really just depend. If someone comes in more severe, I would be able to spend a little bit more time and talk about it. Otherwise, it's just a little bit here, a little bit there, just kind of whispering in their ear almost. And as they would continue to come back, we could talk about it more and more, and they could implement things. So I only worked there 1 to 2 days a week. I was literally there six days a month. So I wasn't there long enough to have a really good continuance of care. So a lot of times I would just have to tell them little things to do, and then they could try to do them, and then they may or may not see me for a week or so, which is kind of how it works in my clinic now anyways. So it's really good training for that, at least. But yeah, it could be hard, and especially if I was the only chiropractor in that clinic that day, depending on the time of the year or the clinic that I was actually in. Within the series of clinics I was doing it, I may be by myself. There may be another person. If I was by myself, it would be a lot harder because I would get closer to that 70, 80 range. If there was someone else, I'd be closer to that 50 range. And that's a lot easier because it's like 25% less patient. So I have less volume, so I can spend a couple more minutes. But yeah, it's very challenging when you are expected to perform at that kind of volume. I know Andre, we've had him on the podcast a couple of times. He works for the same company, but his franchise owners are a little more lenient with it, and he's allowed to spend a little bit more time with his patients doing those types of things. Otherwise, it's more of like verbally, here's what you need to do. Let's see you do this real quick. Let's record a video of you doing it on your phone because there was no way I could record anything with a patient working there. So just doing those little types of things.
Yeah, the reason why I ask is because, you know, there are a lot of people that listen to our show, because there's Chiro in the name of the show, we get a lot of Chiros. A lot of these Chiros are new grads, or even not even that new grad, but, you know, I don't want to say they're stuck, but they are in these positions where they have their bosses expecting them to hit a quota. And that's really why I segue to this conversation, because I really want to talk about this a little bit, man. Like what kind of information could you give that person that doesn't have much time and they're expected to give them the flying seven, the cervical adjustment, the side posture, pop, pop, pop. You know, people are coming to the chiropractor a lot of the time expecting an adjustment. And, you know, we talk about patient education, patient communication. What kind of, I suppose, advice could you give to those people that want to implement what we're talking about? They want to implement some of the movement stuff, the exercise science stuff, but, you know, they're not in a gym, they're not dealing with powerlifters, they're dealing with general population, people that have come in for a pop and a crack.
Most chiropractic visits are under 15 minutes. It's usually about a 10-minute visit. A lot of chiropractors will like double, triple, or even quadruple book themselves in an hour, and they'll have all those appointments taken up. And so even then, like 10 minutes, it's not a lot of time, but compared to what I was doing, because I would have 2 to 3 minutes with the patient.
Wow.
So 10 minutes, that's a lot. You can get a lot done in 10 minutes. I like 15 minutes. I personally prefer a 25-minute appointment, but 15 minutes, 10 minutes, you get a lot done, but you have to be efficient. You have to be efficient with what you're doing, how you're communicating, what you're expected to do, what the patient expects you to do, what your boss expects you to do. And in that time, you can build in 3 to 4 minutes, maybe even 5 minutes if you're efficient enough, if the patient has calmed down on the severity level and you can do things. Obviously, you can't take them through all of the things, but you can start with like some pushing or some pulling, some squatting, just showing them how to change those patterns, show them how to cue themselves differently. Like just observing them sit down, stand up, you can automatically just already tell if they know how to squat or not. So you can have them squat without the chair. You can have them just do a box squat with the chair, and you can cue them just basic things. You can build from that in the next visit. You just check in, you see how they're doing. You don't even ask them. You see how they're doing, and then you ask them, and you already know how they're doing, and you know if you can progress it into more stuff or not. Some people just aren't going to buy in, but the ones that do, you're going to notice it because they're going to be doing the things before they even notice that you're making eye contact with them. Because as soon as you do make that eye contact, they're going to try to remember to do exactly what you told them to do.
Yeah.
And you're going to know if they were doing it or not.
Yeah, and I suppose you can always begin to switch out some of the passive treatment time for more active interventions. And what I mean by that is, you know, if you can pick up a way they're moving or the way they're getting on and off the table, the way they're sitting, you know, if something's not right, and they're saying, and they have active complaints, lower back pain, hip issues, or the history is appropriate for this, you know, situation, then you can really work, you know, take that time from the passive treatments and do some active stuff. And what you're really going to do is you're going to empower that person to really get those results themselves. And they're going to want more next time they come. They're going to be like, hey,
Yeah.
you know, I've got a shoulder problem now. What could I, and you're like, okay, you know, let's work on some scapular rhythm movement, you know, let's look at how the shoulders are moving, protraction, all that stuff, rather than just, okay, we're going to get you, you know, supine, and we're going to do a P to A on the glenohumeral joint. And we're going to get a nice little pop there, you know? So in that sense, it's kind of that starting that
manipulation
transition.
takes seconds. It just takes seconds. So if you're good at what you're doing, you have so much more time. So I don't understand why people say that they don't have enough time in 15 minutes. I know with like that PSP continuing ed program I'm doing, a lot of the physios and chiros in there, they are already working in a hospital type setting, and they have 15 minutes, and they're like, well, I don't know if I have time to add in some of these things. And I'm like, you definitely do, because I do it all day. Like if I can do it in 15 minutes or less.
I interrupt this podcast to thank Raisies for sponsoring the Strength and Chiro podcast. Raisies is a family-owned New Zealand business that only produces high-quality, all-natural and clean products. If you're anything like me and you need a protein that tastes good, mixes well and contains no additives or nasty preservatives, this is for you. This protein is New Zealand-made, ultra-filtered, gluten and GMO-free with no artificial flavors or colorings. If you are an athlete or you love to train hard, it's essential that you get an adequate amount of protein. We would like to thank Raisies once again for sponsoring the podcast. You can get 10% off at raisies.co.nz.
Anyone can do it in 15 minutes or less.
Man,
I'm not that amazing.
It seems so short. It just seems so short to me. But
it is very short. But
we're talking about.
I felt really lazy listening to you, Stephen, because I have hours with my clients.
It's chalk and cheese.
I'm thinking like, God, I've only got an hour with this person. It's like, how am I going to condense everything into that hour?
Yeah, that was a struggle for me, like as a massage therapist going into chiropractic school. Like I was used to spending an hour with my clients. And now, I mean, I do at times spend longer. It just depends on the person.
Yeah.
Like I have various times. I just like 25 minutes, but 15 minutes, that's what a lot of people are used to in the US with the chiro appointment. So I generally try to maximize that whole 15 minutes. A lot of times people will schedule a 15-minute appointment. They think it's 15 minutes and the chiropractor only spends 8 minutes with them. So I try to spend as much of that 15-minute. I'll go over it if I need to. I'll spend 25 minutes. I'll go over it if I need to. I'll spend 40 minutes, 45 minutes, and I'll go over. It just depends on the patient.
Yeah, and I suppose you're seeing people as well that are in a different part of their journey, So I know Stephen said in the past, if he has to, co-manage or even refer to another professional, a strength and conditioning coach or whatever, you will do that. We've talked about that a lot. And so I suppose it's seeing people at different parts, general population off the street. And you know what I mean off the street? I just mean like people just coming in with a basic musculoskeletal complaint is going to be very different than having a specific athlete coming in with a musculoskeletal complaint in terms of problem, but in terms of just time spent.
Yeah. And I worked in a similar practice. So when I first graduated, I worked in a practice where I was probably seeing 40 or 50 people a day. And I'd spend the treatment time treating them. And then I would basically get their permission to take the WhatsApp number and I'd send their rehab exercises over later on via WhatsApp until it got to the point where my boss said, "Are you sending people rehab exercises after your clinic session?" And I said, "Yes." And he went, "Well, don't, because that's making me look bad." When I first graduated, it was I wanted to become, I suppose I wanted to embed those skills, those manipulation skills as much as I can. So I figured working in a practice where it was like that, there were 20-minute lists. So you'd see 40, 50 people in a day and it was crack, 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 crack. But even then, like I say, I still felt they warranted some follow-up. I still felt like I hadn't done my job properly until I'd sent them that WhatsApp message with their early stage rehab or whatever it was I was sending them.
Yeah, and that happens a lot. And we talk to a lot of chiropractors that do a similar thing to that. And even talking to Matthew Lewis, who's a PAC, a physician's assistant, he works in a pain clinic and, he pretty much handpicks the patients that he wants to kind of go offline and he's a McGill certified practitioner. So people are coming to him for a script for pain, for drugs, for opioids. And he's looking at people's criteria being like, okay, does your insurance, this is legit, are you eligible for this drug, And he was saying to us, man, this is a cycle. People are on a cycle and a lot of it's musculoskeletal issues and they're on a cycle and no one's taken them off the cycle and said, this is how you move properly. This is how you load your body. These are some strategies. And so he says a lot of people don't want to. It's like they're in the matrix. He's like, they don't want to. They don't want it's like red or blue pill. They don't want to know. So he says, he has to really pick the ones that are open. And then he says, hey, come to my clinic after hours. And then he does the hands-on movement McGill approach. And he sees kind of exponential, fantastic results with these poor people that are on a cycle.
It comes down to, I think rapport and connection with people, I think is a huge part of what we do.
Yeah.
You know, I know within 5 minutes of meeting somebody, or when I was seeing more people from a hands-on perspective. In fact, even now, I know within 5 minutes of meeting somebody whether I'm going to be able to help that person due to that rapport, that connection. Because I think deep down, if you're talking bullshit, that person on the other end of on the phone or the other side of the couch, we've got really strong bullshitometers, and I think we very easily detect bullshit. So I think there's I handpick, I cherry pick clients now based on people I think I'm going to work well with, and the ones that I don't think will gel with me well and the way that I work, I feign I'm not very good with that particular injury, and I ferry them off to somebody else who I think would suit their personality, their character better.
Yep, that's awesome, and it takes you. I suppose it's taking you years to get to that point where you have that ability so fine tuned to know within a few minutes. Boom. Yeah. No.
I grew up in my dad had bipolar and schizophrenia. I think I developed the ability to detect what people were thinking. I'm not talking about ESP, but in terms of my amygdala, my Jason Bourne was finely tuned as a young boy, and I think that has served me in good stead in many different walks of my life. I've always been able to read people very well and use that to enhance their experience.
And so, talking about communication, obviously, just over the last kind of 20 minutes, it's been very obvious the importance of patient communication education. What would you find is the hardest thing to communicate to a patient, if that makes sense?
I think for the client base that I'm currently working with, which is an active population, I think it's that they're not going to lose muscle, as I talked about. So they're not going to lose fitness. They're not going to lose muscle. They're not going to lose whatever performance parameter it is that they're worried about losing as they go through a rehab process. But that's because I've chosen to specialize in an active population. And this isn't just athletes. This is Gen Pop as well. So I think that's, at the moment, my biggest challenge is they see the rehab program, which essentially looks like a training program, and they look at it and they go, well, I haven't got 6 sets for chest, and I haven't got 6 sets for back, and I haven't got 6 different exercises for this and 6 different exercises for that. It's like, no, because you've got 1 compound movement. We might go up to 6 sets, 7 sets, 8 sets. I said, but that will depend on what phase of training we're in, what phase of your injury's in. And I think so at the moment, that's the biggest issue. I think when I was working more hands-on, it was people feeling like they wanted to be cracked. It was like that. I need that manipulation. I need my back cracking. It's trying to convince people actually, your joints are hypermobile. You don't need to be cracked. What you need is stability. You need to build strength around those joints.
That's really what makes a great osteo is knowing, one of the things that makes him a great chiro or osteo is knowing when not to adjust, right? Yeah. And I think that's definitely like an ideology or an idea we covered a lot with Giles from OMT. Do you know Giles at all from OMT?
Yeah. I know Giles. Yeah.
Real good mates with him, and myself and Stephen are working on a book with those guys, the next book, which is really cool, and they've done some really awesome work breaking down the mechanism of an adjustment. But the cool thing about talking to Giles is, he says, passive treatments, they have their place. But when I ask him about exercise rehabilitation or movement, he's like, that takes priority. Giving somebody a progression from whatever you're doing with your hands on to getting that person to move better under load, to certain in ranges of motion. He's like, that's really what matters. I just suppose there are a lot of people out there listening to this podcast that they want to kind of integrate this into their practice, but they may not know how. And so I do love to ask all our guests, who are the people that inspired you? What are your favorite books, courses that you may have done or that you know of? And what kind of helped you get to the point that you are at, that you could say to other people, hey, go check these people out because it's going to make you better?
I mean, I think the problem is with me is I came from so many different sports I drew from a lots of different areas. So I wouldn't say that there was one person. You know, I mean, I'm talking as far back as Arthur Jones when we talk about, you know, the kind of heavy duty, the 1 rep max type training.
Yep.
So I think it has changed across the years. When I was cycling, you know, everything I've done as an athlete, I've immersed myself in that particular sport or that particular, you know, trying to understand that sport as best I can.
Yep.
I think in terms of like lift, I mean, my master's, it was in S&C. My first career in the Air Force, I was an S&C coach. You know, I think it was through, I suppose, I went into the forces not really knowing what to do. I was a aspiring professional cyclist. I had a bad crash, fractured my skull, broke my elbow. Decided I couldn't cycle anymore, couldn't descend because I'd lost my bottle going downhill. And I was like, well, what do I do now then? And a friend of mine had just joined up. So it was by default. In terms of, you know, like mentors, and I think off the top of my head, there's too numerous to mention. You know, I think there's all the work by Brad Schoenfeld and those guys, Danas, you know, these sort of guys are demonstrating now that, well, the mechanisms behind hypertrophy, but also the fact that we don't need to train how we think we need to train in order to produce hypertrophy or power or strength or whatever it is that we're doing. But I do think as an undergrad, I think doing some form of S&C qualification would be one of the best things they could do for themselves in terms of their exercise rehabilitation. You've got your hands-on You've got your hands-on skills and your diagnostics.
Yep.
I think the addition of an S&C qualification in some way, shape or form from a reputable course or college or university, I think would be for people looking to go down the route that I've gone down, that would be the important missing link that Lockie and people like Lockie are trying to bridge.
Yeah, for sure. And I suppose, you know, carrying on with that theme, being an athlete and having that understanding, how do you think that has changed the way you practice over your whole career, if you were to really pinpoint it down to some specifics?
So I think athletes are prone to overdoing it. So I think one of my jobs as their therapist is to hold them back a little bit. I think that understanding that mindset, because that was my mindset.
Yep.
I think needing to know why. As an athlete, I remember a coach of mine, I was cycling at the time. I was a sprinter, so I was a bit like the kind of Mark Cavendish type rider. I could climb, but I wasn't a climber. I could, you know, race the flat, but I wasn't. But put me 250 meters in front of the line,
yep,
and I was pretty untouchable. So this coach had said to me, he wanted me to go out and do 6 hours on a Sunday. And I was like, why do I need to do 6 hours on a Sunday? And he said, because we're building an engine. And I said, but I don't want to build a diesel. I want to build a turbo. I said, so how does 6 hours of a Sunday allow me to do that? And he couldn't answer me. And I think that education, I think, is really important for buying. And I think I learned that very quickly when I was, as an athlete, that if people couldn't give me the answer that I wanted, not necessarily the answer that I wanted, but the answer that I needed, and there was some justification behind that answer, I quickly lost faith in that process and then moved on. I think it's important as a therapist that you walk the walk. You know, when people are talking about, we were talking about some of the stuff that goes on social media, you know, and I think I posted something about deadlifting with bad form, and somebody sent me a video of Eddie Hall deadlifting to show me what good form was like. And I just laughed and sent a laughing emoji back. And I said, Eddie's 28 stone. I said, the reason he rolls that bar out in front of him is because he can't brace when the bar's underneath him. Yep. I said, if you knew anything about deadlifting, you'd know that's why he rolls the bar out. It's got nothing to do with inertia and momentum and all that stuff they were talking.
He also has a thick suit on, which means that The
Yeah, yeah,
differential
absolutely.
force. Yeah.
Yeah, absolutely. So I think I think from my own business perspective, what does being an ex-athlete? Well, it makes me driven. It makes me relentless. It makes me goal orientated.
Yep.
You know, it makes me pretty formidable when it comes to getting people well. You know, what I think the reason, one of the questions you sent across, I think it was the first question you sent across in that list, why do I do this job?
Yep.
Well, there's no greater satisfaction when somebody comes back to you and says, you've changed my life. You know, I've got a guy, he's just graduated from one of my programs. And his GP's consultant told him the morning before we had our first consultation, you'll never squat, you'll never deadlift, you'll never bench again. He's a strong man. So that was the end of his life. He said, I sat in the car and cried. And 12 weeks later, he's squatting, he's benching, he's deadlifting. He's 5 weeks out from his first comp. And that for me that's worth far more than money.
Yeah. I've heard that story, you know, in different ways so many times, and it just reinforces the importance of having a platform where we can have, you know, smart people on, because there's just so much confusion and other bullshit and other people just saying information to appear a certain way on social media. And I just find that so many people get really confused when it comes to this type of thing. What you're saying about being an athlete, you know, being in the driver's seat is always going to be different to being the coach or the person that's doing the programming or the person that's running the team. Having that experience of being, it's almost like being the one. And when I say being the one, I mean like, when you're the person that's competing, you know, everything revolves around you, and it's a mindset, and it's almost a selfish mindset for those that are really high level. Like for the real elite athletes, they have to have that mindset, and it's really hard to understand that if you haven't been there. And I'm not saying you can't. Obviously, people can. There's fantastic people that do that, but I really do. It really does help me understand and help me help other athletes, knowing that I've been where they are and I feel what they feel, and that goes through, you know, so many different emotions, not just the feeling of wanting to win, because knowing what that feels like, the anxiety that comes before competition or the stress that comes with injury, you know, and it's an array of emotions that an athlete will feel. For these types of people that go to the GP and they get that kind of shut down, they get that you have to rest or you can't do this, you know, they get told everything they can't do. And really it's about giving people options.
And giving them permission, isn't it? It's about giving permission. It's like saying, well, you can't do that yet, but you can do this. I'm a week out, so you were talking about how you feel. I'm a week out from the British champs tomorrow. So it's the full power British BPU champs. And there's a whole host of emotions going on at the moment. 4 weeks ago, I tore my quad at the bottom of a squat, 160 kilo squat. I worked around it. I squatted 170 about 2 weeks ago, and it was absolutely fine.
Nice.
But in the back of my mind, I'm still thinking, I've got 180 to push on a week on Monday. Am I going to get to the bottom? And is it going to hold or is it going to go?
And the squat is a very daunting lift. And people that have only done body squats are never going to fully understand the gravity, the magnitude of the situation. Because when I was warming up, I was opening on 360 kgs. That was my opener. I had to warm up to that. And there was a guy next to me and he slipped, and the bar jammed his forearm into between the bar and the rack, and the ambulance was called, and it was a bloody mess. And I remember this is the first time I was warming up to squat 400, opening with 360, and I remember looking over and just being like, I was just laser focused, man. I remember my brother came up to me and be like, is like, how are you feeling after that? I'm like, after what? Like, I knew it happened, but I was like, you know, and man, things can happen around you. Like I said, 4 weeks out, 1 week out, on the day, in the moment when I'm getting under the bar, it's like, okay, the pin's wrong. It's not 9 and in, it's 10 and in, and I'm a little bit on my tippy toes now. This is really bad. It's like, boom, you just go back to what you know. And the coolest thing about that is we often preach to people, make every set, make it perfect, as perfect as you can. And I just love that, because no matter what happened up to that moment, the second I unracked and it was just me in the bar, I was in that slipstream. I was in that one of millions of reps I've ever done. And I just trusted myself. I'm sure you'll do great. I'm sure that 180 will be nice and smooth.
And I think that's something you said there, those thousands of reps. I think what people misunderstand about training is it's skill. Strength is a skill. We have to practice that skill thousands and thousands of times. Like you say, when you stop having to think about, my chest up, back down, this, that, your cues,
Yep.
when that becomes so automated, that's when you can then focus on the weight and think about what it is that you're actually lifting.
People don't understand that when it comes to the 3 lifts or
No.
I suppose any lift, but for a powerlifter, that's our bread and butter. You go hang out with your friends, maybe they're skateboarding, or you go to the shooting range, someone who's really good at shooting, or someone who's a professional driver, or do all these skills, basketball, sports. And when someone's really good because they're into that slipstream.
Yeah.
You're just watching them like, man, this guy's comfortable. And then you take people to the gym and they're like, yeah, chuck on, let's warm up. Yeah, chuck on 20s. Yeah, let's go. And they're just all over the show. They don't see it, because sometimes it's just not very evident. If you go play basketball with a professional basketball player, you know it straight away.
Yeah.
You know it. Sometimes when you go lifting with somebody, it's not so obvious because a lot of it is internalized. It's kind of like not what you're doing wrong. It's what you're doing right. And people don't have the ability to see it.
Yeah.
Sometimes it goes on deaf ears when you're trying to explain it to people, underestimate it. They don't respect it as much as they should. And really, if we could have a world of people that are pressing, hinging, and squatting better, overall the burden of disease would go down exponentially.
That's how I assess. So my assessment is basically those 6 fundamental human movements. I don't do clinical assessments. I don't do Hawkins and Kennedy's test and Near's test and all those. So I get people to squat, hinge, I push, pull, rotate, and I look at some form of gait, depending on what type of athlete they are.
Yep.
And I think through those 6 movements, you can gain so much more information about that individual, the way they move, the way the joints interact with each other, than you can ever get from, an isolated shoulder examination or an isolated elbow examination.
Absolutely, I agree. And all those provocative tests, really they're just created to stress the joint, the tendon, the muscle, whatever.
Yeah, I mean, Hawkins and Kennedy's, my shoulders are both positive on Hawkins and Kennedy's test because it's a pain provocation test.
In isolation.
In isolation.
What does that mean,
Yeah. Like, how do we, when do we ever move like that? And I think that's what a lot of the stuff gets missed in translation. When people are rehabbing people, I think we should be thinking about integration, not isolation.
Absolutely. I agree. Yeah, because I have a friend who's currently a student. He is told that he can only do X and Y treatment. I won't go into any more details because I don't want to give him trouble, but let's say he's told he can only do X and Y based on the school he's in.
Yeah.
He takes him out back and he starts running a functional test on these people and starts having them, work on their tissue tolerance and capacity of movement and their skill of movement. And these people are just getting better. Yeah. And it reminds me of a story that Dr. Locke told me, when he did his master's in physiotherapy. So he did his normal bachelor's, he practiced for a long time, he was a physio for a long time. He went back to do postgrad and he was getting all the people better. And his teacher's like, I don't want you to use what you know. I want you to learn new things because he's like, stop getting people better. Because I suppose there are many ways to implement things to help people get better. This is going to help me segue into discussion on passive versus active modalities. I feel like we've talked a lot about active. I am interested because I know you love active. I love active. I think everyone listening at least understands the importance of it. But there's also a time and place for passive. And I'm just really interested to know for you what that looks like and what those interventions are as well.
Yeah, so when I first started off, much like Stephen, I was working in a practice where I was seeing 40, 50 people a day. And it was crack, manipulate this joint, manipulate the eye, manipulate the CT, manipulate T4, T7. And then I moved so I went to work with a pro cycling team, and I did that for about 5 years. And that was much more deep tissue work and much more kind of patching people up. There was crashes, road rash, broken bones. We had one guy that rode 160 kilometers to finish a stage with a fractured tibia. Cyclists are tough mofos.
Yeah.
And then I went to America. I worked in America with a motor racing team for about a year. So I started to do a little bit more work with whiplash type or associated disorders, which was again a common phenomenon with those guys. And I think the mainstay of my I suppose, my passive treatment approach is manipulations and deep tissue work. I have an acupuncture. I have some acupuncture qualifications, but it's more medical acupuncture as opposed to Chinese acupuncture. I have done some of the tool-assisted massage, the Graston type stuff. And again, I see that massively abused. You know, there's a fairly well-known IFBB pro had some Graston done on his glutes, and the swelling after this Graston was like he couldn't compete. So basically, this has scuppered his chances of qualifying for the Olympia because somebody assaulted him, basically, for want of a better word, which is what it looked like. It looked like GBH with a tool.
It's funny. Giles always says to me, he goes, "There's a fine line between manipulation and abuse." And that's usually informed consent, but even sometimes the patient doesn't know, you know. And I suppose in that case, that patient may not have had proper informed, because they might not have really understood. Because if they understood it was going to be that bad, they would have probably said no.
It's interesting you say that. There's a culture particularly in bodybuilding, where they think if it's not hurting, it's not doing any good. They're hardcore. So the training's hardcore, your treatment has to be hardcore. And when you try and educate them around, you know, myofascial trigger points, now you release a myofascial trigger point, and it's like, no, just fucking push harder. And it's like, I don't need to, dude. I can work with you. You're going to do the work for me by relaxing, and, you know. So, I think that's probably as far as my experience in terms of passive treatment is concerned. So deep tissue, acupuncture, medical acupuncture as opposed to Chinese, manipulation, and some tool-assisted massage for areas where I can't necessarily get with my hands or my elbow.
I know with Dr. Locke, he used to do some hands-on stuff, but he does none now. He's gotten to the point where he doesn't do any, but you know, that's the beauty of it, eh? We have various practitioners, different professionals in different professions. But the one thing that, like I said when I started this podcast, that's kind of threading us all together is this reoccurring theme of movement proficiency, movement, training, load, these types of principles. I've heard you do some videos on it online, so I am really interested to hear your thoughts on a little bit of tendon talk. Let's call it tendon talk, okay? I mean, look, it's commonly, these things are misdiagnosed. These things are overdiagnosed. These things are mistreated. We've got, you know, tendonitis and otis and opathies, and people use different words. And we've got research, you know, from Harvey Lamont stating back, you know, decades ago now, you know, showing, hey, these tissue biopsies are not actually inflamed. It's just degradation, it's degeneration, it's more of an osis, all this type of stuff. You know, it's like a ping pong ball in people's heads. You talk to different people and, you know, they'll say different things. I'm really interested to hear your approach.
Yeah, I think the term tendinopathy essentially means something's wrong with the tendon, isn't it? And I think that was coined by, was it Jill Cook and Craig Purdon? I think were two of the kind of the researchers that created that tendinopathy continuum. So I think when they're in their early stages, tendons have an itis, they have an inflammatory component, but I think that's often asymptomatic. Clients are asymptomatic at that stage, or at least you go into the gym, you warm up, and your tendon feels all right after you've warmed up, so you do your set, and then it aches a bit afterwards. I think that is your itis. Osis, I think this is where it becomes more load intolerant, and I think that's when you start to get the disorganization of the collagen fibers. And I think that's when you start to develop, as I say, the more chronic pain. And I think the word tendinopathy was simply used because, as you say, when we looked at tendons through microscopes, we couldn't see any infiltration of inflammatory cells. It was clear it was degeneration. So in terms of like diagnosis, again, I use load. You know, I think a lot of times if you've got a big guy on the couch and you're a relatively small practitioner, the likelihood of you being able to produce the force that's needed to provoke symptoms in that person's tendon, I think is highly unlikely. You know, I've got guys on my couch who are 150, 160, 180 kilos. These are giants of men, 6'4", 6'9". And yeah, if I did an active resisted muscle test with one of those guys, they'd literally throw me across the room.
Yeah.
So I think fundamentally, again, it's testing. It's going back to those basic movement patterns. You push, you pull, you squat, you hinge, your rotation, and your gait, and finding those movements which are provocative, and then regressing those movements back to the point where you've got the least amount of provocation. I tend to use a standardized 2 or 3 out of 10, which clears within 24 hours.
Yep.
And then reloading and then progressing that regression. So essentially, it might start with a wall push-up, and then we're onto an incline push-up, then we're onto a floor push-up, then we're onto a decline, then we're onto a bench, then we're onto a... And I think for me, that's the part I don't understand why new grads don't get it, because it's so simple. Like what I do when people ask me what I do, it's like I regress and progress exercises. That's essentially my job. I make things easier because that produces less pain, and I then make things harder because that makes the tendon more tolerant of load, and it organizes the collagen fibers and helps the maturation of the collagen fibers, which you can't do with TheraBand external rotations or TheraBand, whatever it is. Once a client's weight bearing, I think the usefulness of TheraBand has gone. I think once you are walking on two legs, I think you're saying you've got a lower limb injury. I think the use of TheraBand is useless because you're already exceeding the load tolerance of that TheraBand.
I suppose it would be different for the shoulder, like for shoulder rehabilitation, right?
Yeah, so shoulders,
because some of those bands are pretty tough,
Yeah, and I think the way I tend to work with people now is I tend to take over the training. So the people I'm working with, and that's across, right from 8 times world Thai boxing champions, UFC fighters, Premiership footballers, elite powerlifters, elite bodybuilders.
Yeah,
I tend to take over the training, and I essentially program for them. So what they get is a rehab program that looks like a training program and is a training program. It's just I've just manipulated their exercises so that we're producing the least amount of provocation while still producing some load on the tissues they've injured.
And will you still see them? Will they still come in and see you in terms of a clinical setting, or are you mostly doing it in the gym exclusively? So
it's mostly in the gym. Yeah, I work out of a performance center. So there's a Muay Thai bad company, like one side of the gym, and then we've got a strength and conditioning side of the gym. I have a clinic room within this establishment, and I have to say I spend most of my time on the gym floor. I spend most of my time watching people move, correcting movement, adding load to movement, progressing movement. I spend like Andrew. I spend less and less time doing hands-on. When I do hands-on now, it's actually more about recovery. So I've got a guy at the moment who's 2 weeks out from his UFC fight, and it's recovery sessions. I'm going in and just flushing his muscles out, loosening his back off where he's over rotated and he's jammed up his thoracic spine. But that's it. I'm not treating their injuries because I'm doing that whilst I'm on the gym floor.
Yeah. And one thing that I really liked, Dr. Locke once said to me, he goes, I spent all these years studying to make it simple, because he'd say the same thing as you. This is so simple. Like, why don't people get it? And it's like, but you look at his workbook and, objectively, it's not simple. It's not. But I get why he feels that way, because to him it is, so he's like, it's simple. Like, I don't get it. This why people don't get it. It's so simple. But then he goes, but I spent my whole life figuring it out, so it's simple. And that's why he makes big bucks. That's why he charges $500 an hour or whatever. But it's that kind of, it's putting in that work to get to that point, I suppose. Because to a lot of people, a lot of even just, how much training does the average GP have general practitioner, doctor, MD have on musculoskeletal issues. You know, I did a course, an online course, the Stanford Medicine online course. I've been doing that over the last few months, and it was on musculoskeletal conditions, and it was aimed at allied healthcare professionals. So you could be or primary and allied. So you could be an exercise phys or massage therapist, or you could be a chiro, physio. But it was also really strongly aimed at the average kind of general practitioner, and it actually talked a little bit, in the kind of the pre-ramble of the course. It talked a little bit about how these doctors need more, they need more training with musculoskeletal issues, and how it's actually very overwhelming for them when someone comes in. Musculoskeletal has become like this thing that can be very overwhelming for just a traditional medical doctor.
Yeah.
And I suppose that's why they just kind of do, okay, here's something to take the edge off and rest.
That's the same with backs, isn't it? If you look at backs and most therapists, it's like they dumb it down to weak glutes or weak core, because back pain is, it's a complex phenomenon. And I think even for people who've been in practice for a number of years, I think a back pain patient walks in and you can never predict how that person's going to react. You have to be constantly thinking on your feet in terms of, right, well, that intervention hasn't worked, or that they don't like that particular movements, despite the fact they've got that disc bulge. They don't like, they don't like flat extension. And, I think that's why undergrad or new grad physios, chiros, osteos default back to, you've got weak glutes or you've got weak core, because it is overwhelming.
Yeah, and also a lot of that comes from not even therapists, but personal trainers, strength coaches, misinterpreting the data and largely misinterpreting professors or iconic people in the space. And I see this happen. I would say 9 times out of 10, I see this happen with Stuart McGill, that his work is misinterpreted and misapplied. People that really understand it, it's funny. You could sit down and talk to someone who thinks they know what McGill is, and they're pretty much just telling you a bunch of buzzwords that have been thrown around the industry by personal trainers. And it's funny. They go, McGill Big 3, the Berg Dog, and the curl up, glute amnesia, or core problems, and these type of buzzwords that have just been kind of thrown around. And his real position on things has really truly been misinterpreted. I mean, this thesis I'm working on at the moment's done a very large review on flexion under load, because it's such a hot topic. And McGill, of course, McGill's name keeps coming up. I've read all his books. I still don't claim to be an expert. I just know enough to know that I respect the man, and it's just really easy to misinterpret what he's saying. But this goes for like Yanda, this goes for lots of people in the industry space. I had a chat with Greg Lehman a couple of weeks ago.
We
had a couple of hours. People would think that me and him would have so many things not in common. People would think him and Locke, for example, who have done an online debate, would have so many things not in common. But in reality, most things align, and then people online take the small things and they blow them up. And they they try to weaponize it against people. Like this person, like Aaron on Squat U said that it's all about core weakness. And it's like, well, go back and listen to exactly what he said. People they often don't read the full context of a post. And I'm sure you have had that many times. People go off at you. And like you said, when we were offline, you're like, did you even read the full thing? Did you even read the context?
Well, it's interesting. The stretching post, I think, has caused the most uproar. So I did a post where I said I see more injuries from stretching than I do from lifting.
Yeah,
I wasn't saying don't stretch and there's no merit in stretching. I was simply saying I see more injuries. It was an observation, and oh my God, like the stretching police were f***ing on me. I even got there was people coming into my DMs. It was like there was not quite death threats, but it was getting close to death threats.
I've had death threats.
Yeah. It's like, wow, how can such an unimportant topic area, how can this create such emotion? It's like,
it's even worse with lower back stuff.
Yeah. Oh, 100%.
Like people just lose their mind. But the stretching thing's interesting because there are a few. I think Huberman did People
Yeah,
like
that's right.
humans,
Yeah,
like
yeah,
everyone's God right now. Everyone just
yeah,
thinks he's, I'm not here to say either way. I'm just saying people obviously look up to him, and he, stretching would be out of his scope.
yeah,
People would disagree and say, no, he's a scientist and he can appraise information and he can appraise research. So that qualifies him to do that with anything. And there's an element of truth to that, but in
yeah,
reality, stretching is most likely kind of out of his scope. So I did watch the video. I think it was a 2-part video, very long,
yeah,
maybe almost
yeah,
4 hours in total, maybe.
yeah, yeah, yeah,
And he was pretty much like, it was very pro stretching. And so I know that's kind of changed a lot of people's minds. And then there are also other people in the industry, like Brooke Bush, like a lot of passive interventions and static stretching, and there are a lot of people that like it. So it's like if you can find a way to implement or integrate, and that's the key thing. I keep coming back to what you've been saying. You've been saying that's a theme, right? I think you've been saying integration, right? Static stretching in isolation, probably not a good idea, especially if you're not active. It's integration. Yeah. If you can find a way to integrate that into a program that where you're moving and you're loading and you're moving well, then maybe that's going to be fine. I absolutely love Dr. Marv, legend, awesome.
yeah,
and it was really cool because he came on the podcast and he really likes PNF, or what would be also kind of similar to METs, right? METs, PNF, very similar.
Yeah.
And I think he said that he PNFs, correct me if I'm wrong, Steve, but I think he said he PNFs almost every patient after an adjustment.
Yep.
Yeah. He loves it, man. He loves it. So, he does a lot of active stuff. He's got pretty much a gym in his office. So he loves the active stuff. He has that squared away. He's
jacked, isn't he? He's a
bodybuilder.
Yeah.
He's a bodybuilder. He ran a successful business. He went to chiro. He only just graduated from chiro school, I think it was last year. So he's been a strength coach his whole life, really. So he understands movement through and through. He's got calluses everywhere on his hands. He's fantastic. I love the guy. And it was really cool because he was like, nah, PNF's like, people hate stretching, but he's like, I take it. We internalize it with the patient, by doing these holds and by making it more active. And it really works for him. And it's funny, all these passive interventions that some people don't like, you can often take aspects of that and integrate active movement into it, and then all of a sudden we're getting better outcomes. You've got a cup movement and cupping, you could even do PNF with cups. You can even do pin and stretch if you can do myofascial release. Okay, people don't like myofascial release. Okay, do pin and stretch, do some active movement. It's like pretty much at every step of the run, if you integrate motion or movement, or load, you're likely going to have a better outcome.
And I think stretching, you could take that back into strength, eccentrics. Essentially, as the muscle is moving eccentrically, it's stretching, it's lengthening under load. I think it's where in that range you decide to, halt that position. So I think there's a lot of semantics. I mean, one of the things that I realised with the whole stretching thing is the people thinking that mobility is different to flexibility. It's like, well, it's the same thing. It's like we're arguing the toss over semantics, over words.
Yep.
And ultimately, is a muscle lengthening, is it shortening, or is it staying the same length? And I think that's where I certainly seem to get a lot of the hate from, was this kind of whole play on words, the semantics of stretching versus mobility versus fucking injury and whatever else it was there were.
Oh man, there can be some really intense, angry people online. We've had death threats. We've had all types. I've had all types of people attacking me, and then you block them, they come back with a burner. You block them, they come back with a burner. You block them. You've got the freedom to become a healthcare professional. So if you've got the freedom to do that, you've also got the responsibility to keep yourself in check, and so I agree people should be able to openly discuss, and I've always agreed that silencing people is not the way. Just having better discussions is the way forward. But the amount of abuse that happens online from people that are meant to be healthcare professionals is outright disgusting, and we need more people like yourself, MOFO, and Stephen, and other people who are doing things properly to continue doing that. This overflow of new grads that are coming through every year have podcasts to listen to, have content to really bite into, and they're not just kind of being led astray by these kind of self-appointed gurus that are just preaching.
They're preaching hate, aren't they? For a lot of time, hate and I remember going into it was a first year exercise education. No, sorry, it was a first year massage session when I was teaching physio. And the guy I was team teaching with, who was aligned with a well-known physiotherapist, just basically went in and said, I don't know why we're teaching this shit. It doesn't work. There's no point in it. Blah, blah, blah. And then basically just told this group of first years that what they were doing was a complete waste of time. And he resented being there. And I was like, whoa, whoa, whoa. I said, surely aren't we here to show them something, tell them our opinion about those things, both positive and negative, and then let them go away and make up their own opinion.
Mm.
You know, surely that's our job as educators, not to indoctrinate into, you know, a particular belief system.
You would think so, you know, but man, many people who are teaching, you know, are often, they're kind of teaching out of insecurity anyway, you know, and you can tell a good teacher is diamond a dozen. Like a great teacher, you can probably think back to your childhood or your time at university, and you can probably, on one hand, remember the teachers that had an impact on your life. And then you've got other people that they really just don't care. They're just cashing a paycheck. And that happens at every run of the educational system.
Yeah.
And so it's like, if people can't get it from that, my hope is that people are getting some high quality content and education from these podcasts, you know, and online posts, even though it's in a non-conventional way. They need somewhere to look to, you know. Obviously, there are other people doing great courses out there and stuff. Like obviously Locke does stuff, and OMT boys, you know, MPI, other people out there doing really cool stuff. But ultimately, it's cool to have someone like yourself on here so we can kind of just pick your brain and be like, man, everyone listening to this is an example of someone who gets shit done and does it properly. Okay, we're going to roll legit or bullshit segment.
So I saw Lockie, I think he said it was something about pain science, and he said, don't even fucking talk to me about that. The interview's over.
Yeah, exactly. Of course, these are some of these are provocative in terms of they're meant to get like it's all in the fun of it. Just give me the best answer you can, whether it's legit or bullshit. It has to be one or the other. Although, you know, people try to do a maybe here and there. And
I was going to say, is there a maybe? Is there a like?
Technically, there's no maybe. So,
right, okay.
Obviously, some people. Obviously, the whole point of it is to kind of like back you into a corner where you have to say one or the other, and it's just a bit of fun, you know. And of course, most people on Instagram get bitchy about it, but it's part of it.
Well, I think if you're trying to educate and you're putting your head above the parapet, you have to take some of the crossfire that comes with it.
You do. Okay, so this is legit or bullshit. So I'm going to ask you a series of questions, or may even be a statement, and I need you to give me, hey, this is legit or this is bullshit. Do you understand the terms of the game?
I do.
All right, are you ready?
Yes.
Massage guns.
Bullshit.
Blood flow restriction training.
Legit.
Dry needling.
Bullshit.
Exercise-based rehabilitation.
Legit.
Static stretching.
Bullshit.
Strength training.
Legit.
The idea that spinal flexion under load is perfectly safe.
Wow, that's a difficult one. That's legit.
Neurodynamic stretching such as PNF or METS.
Legit.
The idea that technique does not matter for injury prevention.
Bullshit.
The biopsychosocial model.
Bullshit.
Pain science.
I'm going to say legit.
Using ice for injury rehabilitation.
Bullshit.
The idea that knees caving in during a squat is not a problem.
Bullshit.
Ice baths or cold water immersion in general.
Legit.
I know because you do that one. That's why I threw it in there.
Yeah.
Being told that you have to rest for a tendonitis or a tendinosis.
Bullshit.
Oh, that's it. Well done. Hey, there were some hard ones.
You can tell he was thinking so hard.
Ones.
So many.
There was a few there. I was like, listen, I think the whole pain science stuff, I think it is people use it to hide behind in terms of their inadequacies in treatments and stuff.
Yeah.
But I was fortunate enough to work with a pain scientist, a guy called Professor Mark Johnson.
Yep.
So he was at Leeds Uni, lead pain researcher at Leeds Uni. And some of the stuff that he was doing with people like in terms of tricking their brain into perceiving things. This thing, he called it predictive coding, which is essentially where your brain starts to associate certain things with certain behaviors. I saw real-time evidence of that in the various experiments that we ran. And although I don't think it's the be-all and end-all in terms of back pain, we've got the whole SERPA movement over in the UK. I don't know if it's the same. I do think there is a component of neurological adaptation that takes place with any injury.
Yep, I'd agree fully. Yeah, I think, man, pain science in itself, and when you actually read the research, some of the base research, there's actually nothing. There's nothing to scoff at. It's fine to implement that into one's practice or their treatment and how they treat or how they interact with humans. In fact, I think it's necessary. It's usually the way, like you said, it's misrepresented by people to kind of further their own personal beliefs or ideologies around what they're doing. But I think it can sit nicely actually even within the biopsychosocial model. To be honest, it's not a perfect model, but it's obviously been around for a long time. I suppose a lot of people need to read the base research on these things, and people think that pain science has been around longer. There's a lot of misunderstanding. I'll just say to anyone listening, rather than, picking out your favorite pain scientist and being like, oh, I'm going to go read this person's blog, just read some of the base research. I feel like it's usually like the safe thing to do with a lot of this stuff. And you'll often find that, it's less polarizing, in reality, a lot of the stuff can be implemented into daily practice, but people don't want you to think that, people want to be like, no, this is bullshit, or this is complete false, or this is pretty much just like the segment we just did.
Yeah, a lot of people seem to try to use the pain science as an intervention, and I feel like it's more of like a bedside manner approach.
Yeah,
I agree.
And if you use it as an intervention, it's because you lack certain skills, unfortunately.
Yeah, that sums it up pretty well. I think you're right. People do hide behind it, and I think it's also really easy to say something doesn't matter because you don't fully understand it or you haven't been able to achieve it yourself. And that's why you get these people that have experience lifting, or you have people who are athletes, have put in their sweat, tears, and years, and then you have a new grad who's listened to one podcast on pain science telling you you're wrong. It's just gross negligence, So I think everyone can do better leading with humility and confidence, but also, like I put a post up yesterday, man, if you have to always be right and you have to always put out this persona that you're the be all or end all, it's like if you're unable to have an open conversation or even admit that you're wrong, then like there's a problem, really, isn't it?
We were talking about athletes, and so if you think about training and your logical adaptations in training, I think rehab is very much the same way. So if we have a physiological adaptation, we have a psychological adaptation, and we have a neurological adaptation. Now, if at some point in your season as an athlete, you're going to focus on one or more of those adaptations, you might spend more time working on your skill acquisition. So you're working on the neurological adaptation. And I think as a rehabber, what you do with each client is you work out which of those logical adaptations needs the work doing. So is it physiological, psychological, is it neurological? And then you target your approach to fit that particular individual. And I think unless you're able to do that from person to person, you end up fixing half the people you work with and not fixing the other half you work with. You've got to be, it's being malleable. I think we talked a lot about integration. I think you've got to be very malleable. I think you've got to think on your feet as a therapist. And I think you've got to think about those three logical adaptations. Some people need more physiological, some people need more psychological, and some people need more neurological. And that's where the pain science perhaps comes in a bit more useful.
Yeah, and it's interesting what you're saying, because so many coaches or therapists or whatever it may look like, people that are training athletes, they get stuck in this dichotomy or this two-way street of, hey, we've got neurophysiological and we've got neurological, or you've got physiological and neurological. And it's extremely important to understand that, man, there are different types of fatigue, or there are different types of stresses, like you're saying,
Yeah.
mental being a large one. And when you actually even look into how CNS fatigue or neuromuscular fatigue happens and the mechanism behind it, it's actually very different to what people think. You know, it's almost, I think I may have even spoken to you about this in the past. It's funny how people get CNS and neuromuscular fatigue and, you know, around the wrong way. I've read some studies that suggest that, you know, there are up to 7+ types of fatigue systems or stresses, including psychological. When we're training, all of these are being taxed, you know, so rather than being like, okay, it's someone's CNS is fried or someone's CNS is taxed, you know, it's like, well, man, let's look at these other factors like their mental capacity or emotional. And sometimes with my clients, I'd say to them, whether we're looking at HRV, you know, heart rate stats, or we're looking at training output or subjectivity of how they're feeling, you know, they'll say, oh, I'm really run down, la la la. I'll be like, look, based on how this has been planned out, you're not meant to feel like this, or you are meant to feel like this. Carry on, you're doing well. Give them a slap on the back, and let's move through to a deload or whatever. But sometimes when it's not expected, you know, that's when I'll be like, okay, let's just have a chat about a couple other things. What has your week been like? Oh, well, I had an argument with my wife. Okay, how did that impact your sleep? Well, I slept on the couch. Okay, so now you've had inadequate sleep for the last 2 to 3 nights. Now we're seeing it's an impact in your HRV. It's your training, your subjectivity of your training's out. You're not feeling good. And you know what? It's not just physiological or neuromuscular. We've also now got a mental and an emotional component that is adding to the global accumulative fatigue that's happening to your athlete. And if you're not willing to ask those questions, and if you're not thinking in those degrees of fatigue or stresses, you're missing. And like you said, you're only going to get you're only going to get 5 out of 10, 6 out of 10, 8 out of 10, 4 out of 10 of the people you see better, because you're not willing to look past CNS and neuromuscular.
Yeah, 100%.
Yeah. I mean, everything you've said about the training and your approach to your rehabilitation, I mean, it's just been fantastic. I really, you know, wholeheartedly agree with that stuff. And I really hope that people listening to this have been able to pick up and get some education. If people want to ask questions or know more about you, what's the best way to contact you?
So we're on Instagram as MOFO Body Mechanic. We're on Facebook as MOFO Body Mechanic. We will be on Threads as MOFO Body Mechanic. We are on Twitter as MOFO Body Mechanic, I think.
Yep.
Yeah, or the website. We have a mofobodymechanic.co.uk website. So there's multiple platforms to get us on. And I respond personally.
I feel like I've kept you too long. Hey, apologize to your wife for me personally for keeping you so bloody long. But hey, when podcasts go well, they go well. It's a beautiful thing. Great synergy, fantastic conversation, lots of content and lots of education. And is there anything else you'd like to say, Mo?
No, I'd just like to thank you both very much indeed for the opportunity to come on board. It's been a pleasure talking to you. It is now 11:15 in the UK. So I'm going to be hitting the hay fairly shortly.
Thank you for joining us, Aaron.
Oh, yeah. Thank you very much. And like I said, it's our pleasure having you on. Thanks for staying and talking to us late so that we can make all the time zones work. And we'll definitely have you back on if you'd like to come back on. I think when we were offline, we even talked about I think you said something like we should do a roundtable. And I mean, imagine doing that, everyone in person. That'd be amazing. But the next best thing is what we did last year. We did like a Christmas special and we had like 4 of us on. It'd be even cooler to have 5 or 6 of us on, have yourself, have Marv, have Locke, you know, and whoever else, and kind of just shoot the shit. So we'd love to have you back on if you'd be interested. Other than that, hit the hay, get some rest, keep doing what you're doing. And if anyone wants to know more, I'll go ahead and post all your information below the video. Plus, there's going to be clips on social media, so keep an eye out for that. Thanks again.
Thank you, guys.
We appreciate you, man.
Thank you.
And have a fantastic night. See you, Steve.